Okay. Okay, so just get that recording underway.
Okay, yeah, that's a recording started. Thanks very much.
Lovely. So I'll just recap. Welcome to everyone who has arrived. I'm sure we'll have more people coming on board. We're here as the Shifting the Balance of Care group doing another virtual engagement session, and I am Fiona Ireland, non-executive director in NHS Lothian, and by virtue of that state I sit on the IJB. We're really pleased to be doing a follow-up session to the last engagement session that we did, and just shortly we're going to ask Lorraine to do a little bit of a look back for us as to some of the things that came out of that first engagement session, and then we'll do three specific reviews that the teams have done, and we'll have a little bit of a discussion after each as to where we might go next. And then at the end we have an open forum. There were lots of ideas came out of the open forum the last time, and I'm hoping that again today we have equally as much discussion. I'm not going to take up any more time. By way of introduction, I'm going to hand over to Lorraine to set off that backward look, as it were. If people are able to put their hands up, I know sometimes it's difficult if you've come in as an external. We do use that function if you want to speak, and between myself and the admin, we'll keep a track on who wants to come in, and I'll kind of try and manage that for you. Okay, so over to Lorraine, and good look back.
Okay, well, good afternoon, everybody. Can everybody hear me?
Mm-hmm.
Yes.
Is it fine? Okay, well, good afternoon. And as Fiona says, my name is Lorraine Cowan, and I'm the Chief Nurse for East Lothian Health and Social Care Partnership, and I'm the General Manager for Acute and Ongoing Care. And when the team got together to plan this updated session this afternoon, we thought it was good to just look back and take some of the areas that you'd highlighted during our session the last time that you would like to see improvements in, or you would like to see more of in East Lothian. So one of the our work is centred around making sure that the developments and changes we make to services, processes, and the way in which we try and pull the various different services from particularly the acute sector back into East Lothian is to look at how we make it patient-centred and the journey is as patient-centred as possible. And one of the areas that came up loud and clear the last time was about providing other services in East Lothian. Now that we've got the East Lothian Community Hospital, and in particular, people were very keen to see more audiology here at the hospital, and to see if we could have the presence of providing mammograms here in East Lothian Community Hospital in our car park in exactly the same way that it happens at Loughborough Tesco's, I believe. And what we've done to date since we last met is we've expanded the number of audiology sessions that we provide here. And in actual fact, our audiology booth is used 5 days a week, 10 sessions across the week. So we're using our audiology booth here in East Lothian Community Hospital to the maximum sessions we have on site. And that's been well received by people, because people then don't have to, the local community don't have to travel away into Edinburgh. We haven't made much progress in getting mammograms on site. We have started conversations with the service to see if they would be able to map that into their schedule. The one thing that we do have to balance that against is obviously car parking on site. And although we've got a plethora of car parking spaces, the increases we've made to the clinics in particular has brought about car parking being pressurised at some times, but we're working on that to look at how we can get our pro cars and our lease cars parked in a different area to give us more scope for car parking spaces. The next area that was a great topic of conversation was lack of affordable housing. And East Lothian Council Housing Department are part of our Shifting the Balance of Care change board. They've been working really hard over the last year in particular around developing a housing strategy and a housing model for the next 3 to 5 years, if I remember. And they're not here today, but we are planning to have them as the first on the agenda of our next plan session, which would hopefully be in October. And by then they'll have got feedback on their strategy and will be able to give people more information on the direction of travel and what they hope to provide in East Lothian in terms of affordable housing. The next area that people really wanted was they'd like to see services moved from Edinburgh to East Lothian, particularly those that are short appointments, clinic appointments that required long journeys into Edinburgh to attend these appointments, and it could be an hour's journey there for a 15-minute appointment and an hour's journey back. And you'll hear from Gordon Gray, our service manager for outpatients and our day services in endoscopy about the many changes that we've made over the last year since we last met and the increases in services that we've got. But one of the recent developments that's proved to be really helpful for patients is those that attend St John's for plastic surgery. They can now have their post-op clinic appointment here in East Lothian, and they're following up dressings and everything done here locally rather than having to travel to St John's. And the other areas, monitoring clinics, so people who have diabetes or attend gastroenterology or rheumatology are having their pre-appointments carried out here in East Lothian Community Hospital, and they're followed up by telephone rather than having to go all the way into Edinburgh to the Western St John's or the Royal Infirmary for their appointment. But Gordon will have that in detail when he gives his presentation and in his video. The next area which we've been working hard on is care packages and being able to make them more robust. And you'll hear from Susan Burton just shortly the ways in which herself and her team have been growing our internal services, that's hospital to home, and our home care services to provide a greater depth and level of packages to the community. And in actual fact, our internal services are delivering the same, if not more, as our external services, and we intend to keep growing those. And you'll hear the many changes Susan and her team have been working towards, particularly to make them patient-centred, to look at particular times for individuals, and to put a review process in to make sure that the packages also provide the individuals with improvements, and that we're encouraging them to be to maintain their independence and improve their independence. And another area that people were particularly keen to have was increased communication, and we have developed an East Lothian newsletter. We haven't sent one out recently, but what people really wanted was that newsletter to include ways of accessing services and any changes to services. And we are over the next month or so really going to get the next newsletter out to highlight the many changes that have taken place, and we'll continue to we'll make sure that they go out quarterly. We haven't managed to do that to date on the regular basis that we intended, but now we've got Jennifer Jarvis, our communication manager, who's absolutely expert in these things. She can give us support to ensure that that's a regular update for not everybody on this call, but for to go out as widely as we can across East Lothian. So the other area that people felt just wasn't at a premium was better transport links, particularly for those to come up to the hospital. A lot of buses don't come past the hospital. They go into Haddington Main Street, and patients and the relatives and carers have to make that journey up. We have commenced discussions with the local bus companies. The discussions are, I've got to admit, are progressing quite slowly, but the aim is to try and see if going past the hospital can be included in as many journeys as possible, and we'll keep working on that. But I have to admit that that hasn't progressed as quickly or as productively as we'd like. And the other area was a single point of contact. And many people on the last call felt that there was too many numbers to call for same services. There was a number of numbers for different services when people were wanting the same thing. And we haven't secured a single point of contact, but many services, for example, Leslie's MSK services that are in the process of reducing those numbers so that we can get to a particular point that all the services have one single number that can be phoned in. We're progressing that slowly, but it is in our intention to continue working collectively in unison across many of the services to look at how we can achieve that. And again, that will be something that we'll include in our communications. Another area, just on difficulty of contacting, is that many people said there was new services that had come into the hospital. And in previous times, there was a directory that could be available on the website of the hospital, and we've started and not updating that directory, but starting afresh and compiling a new directory, which we hope will be ready in 3 months' time to be uploaded to the website, so that people. People, not only the hospital website, East Lothian Council website, so that people can go in and navigate themselves around where they need to contact, or what services are available here on site, and what services we have in our other hospital sites, such as Edington and Belhaven. And lastly, one of the areas that people felt they needed more information on was technology. And I'm just going to hand over to Leslie Berry, because Leslie's team, the allied health professionals, have done a lot of sterling work on this and are continuing to grow the availability of technology. And Leslie's just going to give us a couple of minutes on some of the advancements that they have made.
Thank you very much, Lynn. So yes, our service includes technology, and that includes things like alarms, false alarms, etc. But also we're starting to look at issues which we call smart tech or retail tech. So that means encouraging people to use what they already have in their home, whether it be a smartphone or an Alexa or whatever, and we have lots of training that are available both to staff but also patients too in our clinics, where we can show people and families how to use existing technology to make their life a lot simpler. We also use extensive technology now to support people out of hospital. It's called activity monitoring, and we use a system where we can support people and support their families to make sure that people are managing at home. If you hear funny noises, it's my dog just decided to roll about the lounge since I've been on the call. Sorry about that. So technology is integral through all of our services now, and it can predict falls. It can help with keeping people independent in their own homes. And our service spends a lot of time either training, as say, staff to use that, or for patients themselves. Because COVID came along, we weren't able to do our clinics that we have at our flats that are purposefully designed now with the support of the council to have these flats are set out with all the modern technology that families can use to support independence in the community. We now have opened up in Haddington, and we're opening one in Dunbar shortly. And I think we may have accessed one in the west of the clinic, west of the county as well. So all of this is to move ahead and bring technology through all of the rehabilitation services that we use. Happy to answer any questions.
Is any questions for Leslie before I move on to what we're planning for our next event, or what we're planning to work on over the next 3 to 6 months?
So Jackie Bell's got a question for you. Jackie?
A couple of things. One is about bus services, and I go to the bus forum, and and from Dunbar it's pretty difficult getting up to the community hospital. But one of the issues that the bus companies are saying at the bus forum is post-COVID still having problems getting driver recruitment, particularly smaller companies like Eves and Prentice, because the bigger companies like East Coast can pay more. So, it's still very much wanted. And one of the things we've also been talking about at the bus forum is about demand responsive transport, and whether or not there's a way to use that from some central point to up to the hospital. The other thing, just regarding the rehab hubs, that there was some puzzlement in Dunbar when signs appeared in James Court, and nobody knew what on earth it was. And some people were, and I think it's been there a while, but there was also a bit of concern, and going to look at the flat, that it was up an alleyway, and it's an area with youth problems, but some people were concerned that there's a shortage of affordable housing in Dunbar, and somebody might have been able to live in it, and couldn't that resource have been provided somewhere else, for example within a new build at Belhaven?
I think the issue for us is that we had to get change of use. I appreciate the maybe it was open to a family. I think the success of the clinic that was in Tranent, for not just the Health Social Care Partnership, but also the fact we do a lot of housing assessments within these flats as well, which has been very successful, working jointly with the housing department. So I think it was felt it wasn't just for the Health and Social Care Partnership, but also for the housing department themselves to support people locally. So but we had to obviously wait till COVID was over, and then the change of use had to be put into place. But we are hoping that the locals, people will come and view what we have there, that they will see the benefit of it. So I am hoping in the future, we're happy to, when it's ready to go, show anybody around to show what we're aiming to do, which is to support local communities to stay in their local homes as long as possible.
Thanks.
Thanks for that. Yeah, no, because it appeared, and I said to Jane, has it got change of use from private accommodation? So I never saw that planning application come through.
So I think
interesting, but it is really useful, all the tech. It was just that was some of the comments from the community.
I think what's really important is we've captured your comment, Jackie, and Leslie, can take that away. But I think in terms of from the shifting the balance of care change board, we're very keen that we have as much opportunity to explore with people the benefits of some of the tech, that we can keep people in their own homes. I think that's one of the principles, and it's certainly one of the things that we really want to do. So I hear your comments about the potential for that one flat to have been used differently, but I think there's a bigger community benefit perhaps from having that type of facility. So we'll park. I mean, I'm capturing comments as people are speaking, but I'm going to take Shameen and then see if we can move on. I think we're probably tight on time anyhow, but good to get the discussion. Gets it underway. Thank you very much, Shameen.
Thank you. Thanks, Lorraine, for the presentation. I really welcome the feedback that you've given about the services and moving from Edinburgh to East Lothian, especially the short appointments, because that'll make a big difference. And I just wondered if you're able to maybe, if you don't have the stats today, but maybe delve a little bit deeper of what impact that's made on the number of appointments. For example, at the community hospital, would be really helpful for the public to see that there is that shift happening.
Yeah, absolutely. And during his introduction, Gordon will cover that because we have the number of increased appointments is in thousands.
We-
We're having and it's not just an outpatient. We've done a massive amount of work in endoscopy, and Lindsay is the ward and charge nurse is here with us today. And we are working with NHS Lothian to use every session we've got on site to give local access, but more importantly, we're now running Saturday sessions, and that's proving really helpful for the local population. But I'll just move on quickly, just to give you some indication of what we're planning next and what we're looking to concentrate on next. And one of the areas that you also raised, that the many people at the last session raised, was access to chemotherapy and, more importantly, IV therapy. So there's a number of our population who are travelling to the Western who are having chemotherapy or who have cancer, who require simple IV infusions, in particular blood transfusions. So we've been working really hard with our cancer centre, and we started off with having 3 chairs in an endoscopy suite for the purpose of providing them with a means to give various different medicines and blood here locally. And we've just recognise that we're outgrowing those 2 chairs in endoscopy, so we're in the process of relocating to another area in the hospital to double that capacity, so that more of our population will not need to travel to the Western General, and staff from the Western General come and work with our staff locally and augment the service to ensure that we've got the right skills, the right experience. We're in discussion with the Cancer Centre about looking at giving simple chemotherapy here again, to avoid the local population having to go to the Western General. And as we all know, 2 buses to the Western from your 86 or 84 is a very difficult journey. And our housing colleagues, as I explained, are revamping their strategy for the future. They're coming to do a session, and we're also going to ask our improving the project manager for improving the cancer journey to come and give the great work that they have done, and the people that they have supported and helped by the introduction of link workers. And lastly, we're doing work centred around palliative care. Susan and her team are working with the team from St Columbus to work together to look at being able to provide packages, and also we are in the midst of doing a pilot at the Abbey care home to have 2 palliative care beds, so they're in the community rather than people having to be admitted to East Lothian Community Hospital or indeed having to go to the city. But lastly, I just want to give a plea to everybody. The staff, as you know, nurse recruitment has been difficult across the whole of Britain and in Scotland, and the nursing staff here within East Lothian have all worked really hard with Jennifer Jarvis and have produced a series of recruitment videos that have now been uploaded to YouTube and a number of social media platforms. I would just ask everybody to share those with your local teams, because you don't know who would be looking to either embark on a career as a nurse, or might be looking for alternative. They're looking for an alternative career move, and we would really like the support to share those widely. Thank you, and I'll go back to Fiona, and I'm sure she'll we can move on to the next section or take questions.
I think we're going to have to move on. Nobody's put their hand up really quickly, so I'm keen that we move on, because we're already behind time, which is not good cheering from Fiona, really, but we'll catch up, I'm sure. I don't know who's going to set the videos running. We have 3 videos to have a look at, which I think are really helpful in terms of just setting out the where we're at. I don't know if anybody's speaking to introduce them, or if they're just going to get set running. just set them running. Excellent. Right. So the first one is discharge to assess, which is mainly our occupational therapy and physiotherapy teams. So off we go. Hope everybody can see this.
Please let me know you can hear it.
Yep.
The East Lothian Rehabilitation Service is comprised of occupational therapists, physiotherapists, exercise specialists, assistant practitioners, community care workers, technology-enabled care officers, a driver technician, and administration staff. We're based at various locations across East Lothian, so that includes East Lothian Community Hospital in Haddington, as well as in Dunbar and Musselburgh. Our services see people in their own homes and in outpatient clinics and as inpatients. Discharge to assess is one pathway within our East Lothian rehab service. And discharge to assess aims to prevent hospital admissions or to get patients home from hospital as soon as they can safely be discharged. We know and we understand that patients are happier in their own home and often improve more quickly here. We work with patients to identify any areas of difficulty they are having in managing at home and take them through a period of rehabilitation with our team.
The discharge to assess pathway is a pathway that has been set up and been in place for a number of years now here in East Lothian, and it's a pathway which supports people out of the hospital. We receive referrals from our therapy colleagues in the acute hospitals, and then myself as an occupational therapist alongside physiotherapy colleagues, we would assess that person in their own home on the day of discharge.
The reason that it's so important to see patients very quickly after the discharge from hospital is it often is that initial transition stage where patients may be coming home and particularly anxious about their ongoing rehab, their condition. Potentially they may have had a fracture or quite a significant stroke, and they may be at home and kind of concerned about what the future holds for them.
The first night home from hospital can always be very scary, but knowing that they've got that number off, that they can phone the occupational therapies or the physiotherapies if they have any issues, they are there to support them throughout the day of their discharge and right up until they get discharged from our service. We're there to support them.
I'm an 84-year-old lady who has had a fall in a garden, broken shoulder. Normally, I'm a very healthy, fit person who never wants to be out all the time. They've showed me what to do. They've helped in every way they can.
So from our point of view, from a physio's point of view, we're very much looking at mobility, function, sort of looking at equipment needs for patients, really thinking about their physical goals going forwards, and making sure that that they're safe in their home environment from a physiotherapy point of view.
My job is very much about what's important to that person, what motivates them, what do they need to do and want to do to be able to live independently at home. So that could be anything from managing from that moment you get up in the morning, first thing, getting yourself organised for the day, perhaps managing meals for yourself. If you're of a working age, maybe how you're managing to get back into work as well after illness or ill health.
As a society, we are now using technology a lot more, particularly since COVID-19. In East Lothian, we are keen to support people to know more about what the technology can do to help support themselves and their families stay as safe and independent at home. Within East Lothian Rehab Service, we have a new digital platform, abetterlife.eastlothian.gov.uk. Within this platform, there is a smart house. The Smart House can take you through all the different rooms and to see what technology might be able to support you or your family or friends and loved ones to stay independent at home. These devices are usually low cost and easy to set up. This technology can control items in your own home in a different way, such as your heating, your lighting, security, and using this technology to help you achieve what you want to.
We go out to support them with, equipment needs, or if they're struggling with any transfers, we can practice their transfers with them. A lot of people want to get back to that full independence and not having to rely on their family members or friends to support them, and that's really what my main role is, working alongside occupational therapy and physiotherapy.
We meet so many interesting people, and it's really meaningful in that we are really providing a real specialist service to people in their own home.
Oh, I don't know how I would have done without them, to be perfectly honest. There's just no way I would have managed on my own without the knowledge that they gave me, the help that they gave me to do things and how to do them properly and not hurt yourself. Across
East Lothian Rehab Service, we strive to keep patients at the centre of everything we do, focusing our services in a holistic and individual way.
Okay, I think that gives a really good summary of what's available, and I think it's fair to say East Lothian are trailblazers in this one. I think we have been at this for a while, but we've certainly hugely increased the size of the team available over the last little while. So I am happy. Lynn, I think the videos that have been put up are the recruitment videos. These are service videos that we're looking at just now, and they'll come out separately. I think we're going to get ourselves in a wee bit of a muddle if we start looking at recruitment videos. But I'm just noting the chat as we go here. Sorry. Very, very much East Lothians at the forefront on this one. So I don't know if anybody wants to come in on just quick. If anyone wants to comment on this one at all? Jackie again, Jackie?
It was good to see Jane MacDonald. Did many a home visit with her when I was the ward social worker at Liberton. But interesting to see this new portal. Unfortunately, I now can't come to the session tomorrow morning because it's a clash with the thing looking with Jane Ogden-Smith. Looking at the care home report, integrated impact assessment. But interesting to see this new portal, an opportunity to shop around and see things on tech. Just wondering how people who haven't got any technology and maybe don't have families are going to be able to access that sort of information.
Okay, I think I would probably ask Leslie if she's got an idea around that one.
No, I think this is a question that we've asked, and I think one of the main things about designing this digital site is that we had to be really good on phones. Some of these digital sites are all right, good and well if you've got a computer or you've got a tablet, but actually this was specifically designed to work very well with smartphones. I know that a lot of people, well, some people don't have smartphones, but a lot of people do have smartphones, and it's a matter of probably our services, whenever we go out, should be teaching people, if they are interested, how to use their smartphones to get hold of this digital site. We also acknowledge that we are looking at to improve it constantly. We're aware, for instance, for people with blind problems, that this a digital site's not the best. So we're looking at having a voice activated area that could be utilised. We also encourage people to, we can show people how to use their Apple phones when in fact it can speak and read and things like this. So we're looking at all the technology we can use It doesn't have to be by sight. Sometimes it can be by listening to it. So it's difficult at the moment because we see a lot of evidence that actually a lot of people do have smartphones. There's a lot of people are probably more savvy with digital than we give credit to. But I am aware of what you say. Not everybody has access to this, and we need to be cognizant of that.
And presumably, Leslie, when people are out from your team, they can show it on tablets or whatever that they have, so they can let people see this
Absolutely.
as well. Yeah, yeah.
We show the individuals. We use the app as well to do it as a life curve, which we use as an assessment tool, which is all part of the AGL. So this is it is quite new the way this has been used. As we've said, it's at the forefront. But I am aware not everybody's got it. But I think that probably the way the future is going, that using your smartphone for so much more than just having conversations is probably the way our future is going, I'm afraid.
Yeah, absolutely, absolutely. I'm going to bring Lynn in now, Lynn Jardine.
Hi, yes, thanks for that. My comment or question is a bit of a follow-up from that. I think certainly people's access to online resources is probably a lot easier than maybe if somebody identifies that they would like to try different digital devices to help them to be more independent, but they maybe don't have support on hand to help with the installation of it. And it might not be a particularly difficult installation, but even sometimes just marrying up two different devices to a smartphone or whatever can maybe be a wee bit more challenging for folk. So I was just wondering, it's great if we can signpost people to the particular device or resource that might assist them, but how do we make sure that they've then got the necessary support to get that actually installed?
So there are various sectors that will help you with this. And we do put the links in the website, but obviously you have to use the website. But I also think that this is why our clinics are so important, because what we do, we have physios and OTs in these clinics, but also we have smart tech people there. And what we do is we invite individuals to come and have the assessment, but we will show them in the flat. If that is still not helpful, we can come out and show individuals. But I think what's usually helpful is that we bring them into our flat with their families and friends. If they don't have them, we can certainly help them in other ways. And we show them how to set it up and how. I'm not saying it's easy because I've tried myself, although I am good with Alexa now, but I think it is a matter of having a go. You can't break these things. I think that's the first concern everybody has. But I think that certain things, you need to be shown how to use it. I agree with you. And that's why these clinics have been so successful, because once you've shown the basic system of how one can be connected, then the rest seem to fall into place. But sometimes it is with the support of friends and family. I totally get that. But sometimes it is getting easier. I would have to say the technology, as it improves, is getting simpler. But I still think if you're not, sometimes it's scary. That's what we're trying to overcome.
Yeah. Thanks, Leslie. And thanks for the questions. I'm going to keep moving us on because we have almost caught back up on time, and that means we'll get a really good discussion time at the end. So the next video is about care at home. Again, I think we're probably just going to bring this one up and run it, and then we'll have a little bit longer probably for questions and chat at the end of this one. But we can bring in chat from the first one if people have other things to ask about. Okay. I'm not hearing anything. I don't know if other people are.
I can't hear anything.
Laura's just going to restart it again. We can hear, so.
Yeah. Okay, it didn't come to us.
Okay, hang on.
Oh, Bruce.
Don't you love technology? What was somebody saying about it's getting easier? Technology is getting easier. I think Leslie Berry said technology was getting easier. I'm not sure I believe her right now. Let's have a third time lucky I'm going for. We're with you.
The home care service has been a long-running service and existed for quite a long time. The emergency home care service is a bit of a more unique specialist service. They respond to falls, emergency situations and home care alarms predominantly within East Lothian. So the emergency care alarms are triggered through various methods. It can be motion sensitive, there's sensors in people's houses, it can be buttons or cords pulled. There's actually motion sensors on doors and windows as well in some cases, which then produce a response from the emergency home care service.
Our job's a small team that reacts to the community alarm of residents in East Lothian. We're based in a community hospital, but we go from Coburns Path to Musselburgh, Humby to Portsea, and we cover the whole of East Lothian.
So the aim of the emergency home care is to assist people to remain living independently within their own homes and actually reaching the potential and living the lives that they deserve to live and choose to live. Once they've responded, once they've assessed the situation, responded, got the person onto their feet and got them back up into a safe position, they'll assess any potential follow-up so they can make referrals on to other health professionals such as occupational therapists, physiotherapists, GPs and such like.
What we do with our onward referral is making people independent living at home. It's a very rewarding job. You're looking after people who just need a wee bit of help. You're looking after it all.
Part of the emergency home care service, they provide palliative care for clients within their own home, so support people to remain at home at the last stages of their life, and part of that is to make people as comfortable and safe and supported and to live a dignified end to their life in the way that people would choose to live within their own home.
We take stress away from families, we care for our clients with respect, we go in and we look after their family member.
We've got an ageing population in East Lothian, so the requirements and needs of the service have significantly increased, and in response to that we are in the process and will very soon be introducing an increased service that will be a 24-hour service, 365 days a year, that provides emergency response to that ageing population, again to support them to remain within their communities.
So Hospital to Home was a government funded scheme that was set up in 2014, and Hospital to Home allows us to discharge medically fit patients from hospital into our care so that they're home, which releases beds in hospitals. So we first started off with one travel route and 3 carers, and at present we now have 11 runs and we have over 50 carers. Hospital to Home uses a rehabilitation approach, which allows us to review all our patients, the band 6s that work with Hospital to Home. We review on a continual basis. We do have feedback from the carers, but when we go out and do a review, this allows us to see whether the packages of care need to be increased or if they need to be decreased. We also work with GPs, OTs, who also review as well on a daily basis. We work with them as well. So this allows us to see where we can move people on, rehabilitating them, or if we need to increase their package and they wait for a care provider to take on.
They may find themselves having been discharged from hospital. They come into our care and we give them the same standard of care as they would receive in the hospital, which is good for them because they're now in their own home. It makes them feel comfortable. They know their own surroundings, and it's good for family members as well. brings all the family back together again in one place. I think the positivity is tenfold, and the difference that you see in these people when they are home from when they were in the hospital is immense.
It's given me my independence, and I'm able to do things that I couldn't do before. And that they're all so nice and they're obliging. And if it wasn't for them, I'd still be in a hospital bed.
We have a really good team here in Hospital to Home. When I first started 7 years ago, there were only a half a dozen of us. I now find myself in the middle of 50-something people. We make a big difference to people and their lives and their families. Seeing people who have came home fairly ill, not very independent, and we've guided them onto a path where they are now much better and more independent. And I don't think there can be a greater satisfaction than seeing someone progress that way, you know, physically with your own eyes, with your own help.
They're so helpful and understanding. That's what I like about it. I wouldn't have a word said against them. I enjoyed my time at Haddington. I was glad to get home.
That's really great to see patients reviewing the service that they're getting just quite so positively. It really is heartening, isn't it? So over to any comments or thoughts on this particular development. I think to go from 1 route and 3 carers to, I think she said 11 runs and 50 carers just shows how much demand there is for the service and how well we've addressed that. Marlon, do you want to come in? You're on mute at the moment, Marlon.
Oh, it was just really, really fantastic presentations. What I was wanting to ask is, do you have to register in order to get the emergency home service, and how would a person distinguish between calling that and an ambulance if they took a fall or had a bad turn or something?
Okay, so I don't know who's best placed to pick that one up. I would answer from my own historic knowledge of these services, but it is historic, so I'm not going to do that. I'm going to let somebody who's much more up to date than me answer. I think Lorraine, who have you got for that?
Susan Burton's going to answer. She's all geared up here to address that.
So the activations of the CAS alarm are done via the CAS alarms that are installed in the house from Leslie's team. So people register for them, or it's something that's offered to them. I think there's a monthly charge to that. They give a next of kin contact detail, but it depends on how it comes through, because when the button's pressed, there's a call handler in the contact centre that's from Iceland and Pencil that's able to speak to them to find out what the problem is. And then that's what triggers the activation of what type of response is needed and how fast that response is needed from the emergency care service. So it falls become the highest priority. We also get no voice contact, so that could be that it's activated from a fall because there's a fall protective in some of the alarms, but that is much assessed and reviewed by Leslie's team at what level of support and what level of equipment it requires to do the property.
Thank you.
Thanks, Marlon. So I suppose really what you're describing is that when the alarm is pulled, there's an assessment made of where and who is best placed to answer that. I think is that a fair comment?
Yeah, so a lot of the time, the nurse care service, if there's no voice contact, we don't know what's happening. Because we do get false alarms, it always comes to our team. We go out to do the initial assessment, and if an over referral for an ambulance or any assistance is required for any such reason, there could be multiple reasons for called out. We will go and make an initial assessment and call whatever help is required.
Yeah. Which it's really good to know that there's that sort of assessment of the need at that point, rather than there just being an automatic response. So my historic answer would have been very different, and people who were around 25 years ago will know that it would have been very different. Leslie.
Just to say that we now have a full service, so if somebody's been assessed, as Susan rightly said, and we feel that there's some input that we can do, that will go through to be assessed by our full service. They will either have a visit, a more kind of in-depth look at their home circumstances, and any therapy if required. We also have FULS classes, etc., and can provide equipment. So we try not to say a fall, so what? We try to do something about it now and try and prevent further falls in the future.
Yep. All good stuff. John.
And finally, if going back to Marilyn's original question, if someone doesn't have a CAS alarm and they are not sure whether to phone an ambulance or not, if it's not a life-threatening emergency, then NHS 24 would take the call on 111 and they would do the assessment and point the individual in the direction of the appropriate service.
Yeah, good advice there. Excellent. Okay, I don't see any other hands up. I'm just going to check. Oh, Jackie.
Yeah, it's just one of the things that, you know, hospital to home and the review and everything, and then passing on to other services. That my experience when working was that the hospital to home type service could get clogged because of getting carers, you know, ongoing companies or whatever, to be taking on packages, and that being a particular issue in rural areas, you know, thinking of the sticks of the Lammermuir villages, things like that, of, you know, companies who aren't keen to go out to the likes of Oldham Stocks and even beyond Oldham Stocks. So it's just wondering whether or not, particularly with all the other pressures that's been shown on the NHS this winter, whether or not that is proving to be a problem in that movement, so you continue to have the flow.
Susan's best placed to answer that, but just to answer one element of that, Jackie, in terms of rural areas, Susan and her team have done some work recently and have actually put in a rural run, as they call it, to start addressing those who we all know are in rural areas and can wait some time for care. But I'll hand over to Susan about the progress of moving on from hospital to home and what plans we've got. It is difficult for the external providers to recruit, and I'll let Susan just outline the plans that she's made.
So we've got a team from the hospital that's called IPAT team, which is a social worker team, nursing element onto that. So we're constantly reviewing packages, any high risk things that come up, to see what we can do to provide service. As Lorraine said, we have started a rural run, so that was up and around the back of the Lammermuirs, and we have to keep responding and changing the service needs independent on what's happening with the third party providers. So our external provision. So there's constantly a review of what's happening with them. If there's a provider in the area, we will try and pick up the more complex of areas. We do the majority of double up packages here in East Lothian across home care in East Lothian, council services and hospital to home. And we're constantly looking at the best way to provide care to people in a patient-centred way. What we try and do is, if we've got both internal services in one area, we'll try and do what we call reviewing of the runs to make sure that we've got not got two carers going up the same street, and so we can provide a more diverse service to the whole East Lothian and cover. We do predominantly end up taking on a lot of rural areas, Gifford, Whitekirk, Sydenham. So as the demand comes up, which it is great, and it keeps moving and changing as the 6 months goes on, and you do predominantly see that through hospital discharges, and some people in the community that are sitting as high risk needing care. Sometimes because we've got care in that area, we're able to reduce the risks. Not all get the package that we're there, but within the team working, we do try as much as we can to get a service to someone, and also using a lot of the resell, what we can do with the outreach with referring on to lunch clubs. If anything, sometimes it's not always just your formal package care for your activities of daily living. A lot of the other times there's a lot of other things to do with that, and that is something you'll constantly review. And through that review process, we will pass certain elements of the care package onto another service, and that then frees us up to then pick up other care needs and then the risk care needs for the community and hospital discharge as well. So we do work hand in hand with both of them along the way to make sure that we're not always just prioritising hospital discharge, which is important, but we're also trying to meet as much of the demand of the community, especially the high risk care, to avoid as many people going into hospital for a social reason, and that their hospital requirement to go into A&E is actually a medical one.
I think that the two words that are springing out at me as we hear about these services is about flexibility and agility, because actually that's what's making this really work for us, isn't it? It's the ability within your services to be agile to people's needs and to be flexible with the staffing that you have to meet the range of different requirements that individuals have. I'm just thinking to myself, and perhaps speaking out of turn, but when you're in the chair, you're allowed to, I think. And I'm going to suggest that perhaps when we do the next newsletter, it might really be worth us looking at some of the data behind this and actually saying just how much service, how many hours of care we're managing to deliver this way, which would allow us just to see, the difference that we're making for people. And I appreciate that not everybody's getting perhaps the full package that they might ideally, but I think you're covering as much as you can with the service that you have to make it as safe as possible for people. And I think I do think we need to just look at some of those numbers. It would be helpful for people to understand how that's grown over time.
ECS, actually, we just pulled the data. I was working on that this morning. ECS last week were covering 580 hours of planned care out with the unplanned care, which is the calls from the CAS alarm systems. So that is for some of our high risk clients and for palliative care patients at the moment. Hospital to home were providing 1,100 hours of care to 95 individuals. As I say, a lot of that is it's 12.5 runs we're at now. 5 of those runs out of 12.5 are double up runs. So it shows the areas in the community that we're constantly providing for. And home care are providing 191 clients, and it was it's 13,000 hours, 1,300 hours of care.
Yeah.
So when over 65s are receiving in and around 7,000 to 7,500 hours of care in a week to the community, we are doing a lot of that when you take out the learning disabilities side of that for the population. And we do have some predominantly younger people that have got challenging needs or challenging behaviours. Because the infrastructure and teaching and training that we give to our staff to try and combat these issues, to keep people in the community. We do find the providers will have a tendency to find that more of a struggle with the way that they're set up. So we end up finding that those services end up moving to our teams to keep that sustainable in the community.
So we didn't set that up. I mean, she wasn't looking at the numbers because she knew I was going to ask that question today. But it's really good to hear the numbers. I think it would be really good to share them with the stakeholders. The other comment I would make is that the other thing we need to look at, and perhaps this is for our future as the Shifting the Balance of Care change board, is just what it costs for different models of care, because actually if we can provide more care, shifting the balance is all about bringing things to the community. And I think it's really important that we look at how we spend the money that we have to the best effect to look after the most people and keep most people in their own homes. So I do think there's some real mileage in this one. Jackie, you've got your hand up.
Yes, sorry to come back. It's just thinking about these packages that there was the community hub in Ward 2 at Belhaven, just wondering what is happening to the local hub whilst Ward 2 is closed for the remedial works. You know, where are people based? Because Ward 2 could be another place where people could go for, you know, daytime assessment and more use in community, you know, looking at some of the how to use tech, things like that.
Yeah, I'll pass that back. I'm passing most of this back to Lorraine, but we'll pass it back to Lorraine and see what she...
So the services such as Leslie's services, etc., that were based in the hub have been relocated elsewhere, whilst we're getting the water quality upgrade done at Belhaven. Ward 2 hasn't started that work yet. It's not due to commence until the end of March into April. So the hub wouldn't be available again, probably not until May or June time. But the plan would be the services, the staff that were co-located there we would look at what we would be providing in that area. And Hospital 2 Home and Home Care had a base there, so they didn't have to. They could start off from there.
Okay, but I think the important thing, Lorraine, and this is that we would anticipate that hub will be re-established once we have sorted the
Get the work done.
Yeah, get the work done. Yep. Okay. Okay, I'm going to move us on to our third and final little video. This one is actually about the day services in East Lothian Community Hospital. Gordon's probably quickly looking at his numbers, thinking she's going to ask me that too. But we'll watch the little film first.
Welcome to East Lothian Community Hospital. We first moved in March 2018 for the outpatient department. The rest of the building was opened up in November 2019. We have been able to attract an awful lot of new services and businesses into the area, and we're continuing to do that and hope to expand it over the next 2 or 3 years. Originally, from an outpatient perspective, we had 30,000 outpatients on this site. That has now moved up to very nearly 50,000 outpatients per year. So there's something we're doing that is attracting patients and services onto the site. Residents can now access the following list of health services locally: adult ear, nose and throat, abdominal aortic aneurysm, commonly called AAA, adult psychiatry, antenatal services, audiology, cardiology, dentistry, dermatology, diabetes, gastroenterology, gynecology, lymphedema, minor ops, various monitoring clinics, MSK, neurology, palliative care, phototherapy, ophthalmology, orthopedics, osteoporosis clinics, plastic surgery, podiatry, rheumatology, and urology. During COVID, a lot of our clinics had to pause or in some cases close. Post-COVID, we're almost back to normal now, and we're back up to what we'd be expecting to see on an everyday level. Whilst we were closed for COVID, we made really good use of new technology. Near Me was the name it was given, and that allowed consultants to speak to patients in their own homes over, of course, video conferencing type facilities. And the benefit to that was it enabled patients to continue their journey and not miss out on their clinics.
Having local services to the people of East Lothian is a massive thing. It means that people aren't having to travel into Edinburgh on the bus or train service. We have fantastic parking facilities now, so we have disabled areas. It's accessible for all because it's a fantastic new building.
Almost always, when a patient's being admitted to the department, we walk them from admissions down to the room that they're going to get changed into. And they'll always say, "Oh, this is nice. Oh, how old is this building?" You know, and they always ask questions about it, and they all notice just how fresh and light an area it is. It's fantastic.
So there's 1 or 2 new developments. We've really ramped up the amount of nurse-led clinics we have, and what they do is allow for a patient to come and get monitored routinely, and if there's anything that's shown up in that monitoring, we can then make an appointment with a consultant. So there's 4 services at the moment. There's gastroenterology, there's renal, there's diabetes, and there's rheumatology. We will be expanding that to include a couple of new ones in the future, one of them in lymphedema, the other one we're still in negotiations with the services. One of the other developments has been UV phototherapy, whereby people who would normally have had to go into Edinburgh, specifically at the Lauriston building, can now get that treatment here. It's a course of between 10 and 15 weeks, and you come twice a week and go into a phototherapy booth. It's nurse-led service. It is really popular and saves patients having to travel into Lauriston. It's got to a stage where we're almost thinking of doubling our capacity by running it 5 days a week as opposed to 3 days a week. Okay, a couple of other new clinics coming our way soon. By the autumn of this year, we will have a travel clinic, which will allow people to get their vaccinations to travel aboard on site here, as opposed to having to go into one of the clinics in Edinburgh. We have given a few rooms to community treatment and care services. CTAC is a service that would predominantly have been provided out of a GP surgery, but now it's provided by the partnership, and it's things like wound dressings, ear irrigation, that sort of stuff. And finally, we've got 2 clinic rooms which we've upgraded their air changes to allow us to do minor ops on site here. Our endoscopy and day service unit continues to expand. From the old Rutlands Hospital site where we had 17 sessions, we have the capacity to go up to 30. Currently we're at 24. So we've increased our throughput by 41% to date. Gastroenterology tends to be our biggest service, but there are others. There are urology and there are gynecology. Also within the unit, we have an IV therapy unit, and that's a collaboration between ourselves and the Edinburgh Cancer Centre Haematology Unit. What this allows for is patients to come here to get their blood transfusions, their iron transfusions, rather than having to go up to the Western General Hospital in Edinburgh. It has been a real success story, both in collaborative work between us and the Western General and patient feedback on how much they prefer being able to come to a local site rather than having to go to the Western General.
We also receive cards from patients who have been for procedures, kind of thanking us for what we have done and even thanking the hospital.
We have a discharge lounge within the department, and it has a whiteboard on it, and the patients are invited to put comments, you know, negative, positive, whatever. We love all feedback, but I have to say they're all positive and they're quite complimentary, to say the least.
As part of our endoscopy unit, we also have a teaching facility with a seminar room where we can view what's happening in either of our 2 procedure rooms. And that can also be transmitted out with this building to other sites, be that Fife, Borders, further afield. And that's a real boom to have that on site. We're getting to a stage where we're going for something called JAG accreditation, JAG meaning the Joint Advisory Group, and it's part of the Royal College of Physicians. And should we be accredited, we'd be one of the first organisations in Scotland to be so awarded. And that would be a bit of a feather in our cap. And we're actually in the process of applying for that as we speak at the moment.
Okay, thanks, Gordon. So I suppose the first question, Gordon, has to be, are we still in our application process for JAG accreditation, or is it through?
We are still in our application process. They visited us in the middle part of November, and they have a 6-month deferment. They have 1 or 2 things they'd like us to do physically on this site and in collaboration with the wider NHS loading service around waiting list management and the DNA rate. And so collaboratively we're working on that. The actual changes they're wanting to the physical environment, to be fair, are really minor. And all of that will be done.
So that's one definitely for the next time in October to hear where we're at with that, definitely. Okay, any thoughts from anyone on that little film, which really does show just how much the community hospital is doing in terms of activity? John Hardman had a question in the chat, and I wonder if it's actually worth picking up. Because John, I think you were asking specifically about blood transfusion access for GPs, whereas I think what Gordon was talking about there was specifically for patients in the oncology pathways. I wonder, Gordon, if you can pick that up before we come to Jackie.
Yeah, no, fair point, John. And here, Lorraine, we are working on expanding that to make that accessible to GPs. So that's why we're moving it from its current location into a bigger location, so that we'll have 6 chairs instead of 3. And I appreciate demand probably wouldn't fill that on day one, but it gives us a bit of room to growth. But we've got to get the room ready. We've got to get it fit for purpose. It's got to fit in with infection prevention and control and all that. It takes longer than we'd like, but it's been worked through the system.
Okay.
And we're working with our lead consultant here and referral pathways, and we'll be hearing from Jennifer soon, John, and we have refined that. It's just getting that correspondence out to GPs at the right time when we're then ready to start. And as Gordon says, there's a few things that we need to be put in place from an infection prevention and control perspective.
John, do you want to come back on that point?
Yeah, just to reflect the fact that that's really great work, and it'll be great once that's up and going, particularly for some of the very frailest and most vulnerable people in our communities who really struggle to access treatments that make a massive difference to quality of life. And I'll be happy to kind of help communicating those messages to GPs once that service is up and running. The other really helpful thing that I want to point out is the monitoring clinics that Gordon was mentioning, taking bloods for rheumatology clinics, renal clinics, diabetes and gastroenterology, because one of the challenges of the Near Me service and consultants doing video assessments of patients is that very often, if patients had attended a face-to-face clinic, they would have had blood tests done in the clinic. And one of the challenges that primary care and general practice in particular has faced has been that we have had a massive influx of consultants quite innocently and reasonably saying, oh, well, just get your bloods done at your GP practice, while GPs have been managing lots more stuff on, through the pandemic and since then as workload has increased massively. And most practices just don't have capacity to do those blood tests a lot of the time. So those clinics which have facilitated those blood tests for secondary care, where the blood tests then go back directly to the clinician that's asked for them, have been absolutely vital and really important, and we're hoping that they can get expanded at some point in the future to make it much better for patients to get those blood tests done. But I'll maybe take that up with Gordon at some other point, because I know there's not necessarily capacity for that, but it'll be good to know what work can be done. Thanks.
No, that's
just on that, John, we've been quite agile with how the monitoring clinics run. They were service specific originally. We've now made them generic, so they can get booked in by anyone that needs blood. And Lindsay will be able to speak a bit more eloquently about it than I can. But we've kind of just thought we can't just have renal on a Monday if someone else needs it on a Monday, so we make it open. It's just a question of getting the booking services correct at the front end, and that we've done working with our partners in central Edinburgh. So that's worked quite well. Sorry, Fiona. Jackie wants to come in.
Yeah, Jackie.
Yes, it's really good to see some of these coming out, that being somebody who goes on the long trek to the west, and even by car it can take an hour and a half and then you can't park. So really good to see some of this. It would be nice to have the orthotics brought out, having now been waiting 3 and a bit years for an orthotics appointment. But the other question, though, that we've been talking about since the planning stage of the community hospital is minor injuries. We lost Belhaven, and that the Eddington is currently suspended. Particular issue with minor injuries is minor injuries for children. which was available at Eddington, and now you know you've got to go into town. They say don't go to A&E unless you have to, but for many people that there isn't choice, you know, and it would be so good to have that minor injuries more available. And people do keep asking for A&E, but that's less possible. But certainly minor injuries, carrying on the request.
Okay, so I think that's probably out with the terms of reference of our shifting the balance of care change board, to be honest. But I'm happy if either Lorraine or Gordon want to comment on that. I'd have thought that was outside of our remit. I think it would be a wider IJB issue.
Yes, it is a wider IJB issue, and there has been some discussion locally recently around minor injuries, and Bruce Dickey, who is one of the project managers, you know, was and I don't know if it's finished or not, was looking at what if we located a minor injuries unit here in Slogan Community Work, so what would it look like, what do we provide, what are the hours? And he was scoping numbers a few months ago, but I've got to be honest, I don't know where we are with that. I can certainly find out.
Yeah, I think that would be helpful, but I do think it's something that would be an IJB issue, Jackie, rather than this particular change board's decision to do something like that. So perhaps it's out with the scope of what we can commit to here. Tom,
but, you know, it's appreciated though if somebody's looking into it, because you know, you're really the only change board that's having sessions like this, and it would be good if the others did too.
Yeah, well, we hope they'll learn from our lead. We're trying to get in there and show them the way. Tom Lynch has put a couple of comments in the chat. I don't know, Tom, if you want to come in, but one was actually very complimentary about the discharge to assess team, and I'm sure that Leslie noted that one as it came flying past. Which is good to read. And you were asking about palliative care services, Tom. Do you want to pose a question that the team can answer?
It was really as literal as it sounds. I had seen that pop up on the presentation, and I just wondered whether there's new developments in community hospital with respect to palliative care services, or whether or actually what is existing. I think there's probably a lot of us that feel a little bit remote with some of our palliative care support over the COVID years and maybe beyond. And so it would be nice to know what additional supports are out there, or if there's new things coming that we can access.
Okay, so is that a Gordon question, I suspect?
Probably in two parts. I'll answer one bit. We have Duncan Brown. He comes and had said, can you run a clinic from the outpatients here? And we said yes, and he's now been doing that for about 4 months with some success. It is a bit of a slow burner, and I think it's maybe a confidence thing with the wider palliative care team.
Yeah. So Dr. Brown and the palliative care team had recognised that there was a need for having local clinics so that people could come in, have discussions, they could support them, they could look at signposting them. So we've started a clinic here on site to allow them to have that space to do so. But from a palliative care perspective, we do have palliative care beds here in Ward 1. They previously were there was previously beds in Edington, there was previously beds in Belhaven. Unfortunately, there's work being done in Belhaven, but the plan would be to return those to Belhaven, and we take a flexible approach to our beds. So in Ward 1, we would we originally started with 2 palliative care beds, but now we have 3 and 4 people at sometimes, and we most recently and Susan and the team, Susan and the ICAT team, we review everybody, and most recently we took somebody from the Western General, and he was only in his 40s, to one of the palliative care beds in Ward 1, whereas previously we would have admitted people over 65. There's also 2 beds at the Abbey that we've opened for palliative care access and admissions that we're doing as a test of change. But the other District nursing are doing a lot of work around palliative care, and Jane Tate is looking at how the new specialist practitioners they've put into district nursing could support people more at home. But the most positive development is that St Columba's have started a team in East Lothian providing care to those hospice at home for those that need it in East Lothian. However, the care they provide is very limited. They don't do medicines, they don't do certain things. So Susan and her team are working really closely with them. So now what happened previously was people would refer them to hospice at home, would refer them to Susan's team for care that was needed. Now they all go to Susan's team, and Susan's team will rate these referrals, but also identify what is the best team to be providing this care, or can we provide it together, and then have a once a week teleconference to allocate that care and make sure that we get the right care at the right time to those who are needing it, who are either end of life or are palliative in the community. And the hospice at home are looking at providing more carers to allow Susan's team to work closely with them and use them as best we possibly can, along with our emergency care service, who will provide that overnight element. So there's been a lot of developments in the last 6 months. What we need to do is consolidate it and make it sustainable moving forward.
So Tom, is there some new stuff in there that you weren't aware of? Is that giving you a wee bit of a glimmer of hope?
Yeah, definitely. There's we welcome all of that change, and absolutely, as Lorraine says, it's consolidation with new services and making sure that they are delivering what they're aiming to deliver. I was keen to see about sort of day centre support for palliative care patients, and I know I often find that sort of lower level input that some folk need, that is provided in that sort of setting, that we just don't really have in East Lothian, that you probably would get up in Edinburgh, but I appreciate that's outside maybe the scope of here.
But it's something Tom we could take on board and have a look at.
There we go. That's another thing for an update in October. We're collecting quite an agenda for October. Okay, so in terms of our agenda, it says that at this stage we should be doing a wee recap of what we've heard and where we're at, and then having an open discussion. I'm not proposing to take 10 minutes to recap on these 3 films. I'll tell you a few things that I wrote down as we went through. The first one was, why does car parking always appear as the first problem? It appeared as the first problem last time, and I'm convinced it's not on the shifting the balance of care's agenda to sort car parking, but hey ho, it's there every time. But I do think we've seen some really good evidence of person-centred approaches to local care, and I think that's what shifting the balance is about. I think there's some areas where people have absolutely accepted that there's more to do, and there will always be more to do, but some of the commitments that we made previously, we perhaps just need to really pin ourselves down on. Things like the quarterly newsletter, we just need to absolutely nail it, and Jennifer needs to make sure that we deliver that. It's not for Jennifer to deliver, but I do think we probably need a wee prod to deliver that. In terms of some of the services, there's obviously more to do there, but I think what I'm hearing is that there's lots of work going on in the background. It's about how do we share that out so that everybody knows as things change. Tom, as a GP, to be asking what we're doing around palliative care, there's something that we really do need to make sure that we're communicating out as these things change, and not just at events like this. So for me, that's probably the key messages for us as a group to consider. I don't know if anybody else wants to come in at this stage just in terms of what they've heard so far, because I think the next bit we're going to go into is really the open discussion about and what's next. And the and what's next is maybe more important because that's what's going to give us our work plan, if you like, for the coming months. So happy to take any comments. If you can use the hands up chat facility, if you can. If you're not able, then do just shout out when there's a wee gap. But try and use the hands up. It does make it much easier. Anyone or no one? Because if no one wants to, that's absolutely fine. I can prattle on until 10 to 6. Believe me. I'm sure you'd rather hear some other people.
Can I just give a couple of updates from the video?
Yes.
The phototherapy where we were talking about expanding it, we have now expanded it. So that will be running 4 days a week as opposed to 2 days a week. So instead of treating 30 patients at any one time, we'll be looking to treat 45, 50 patients at any one time. And we really do expect to be seeing 60,000 patients this time next year on this site. So that will have doubled from the old Woodland days. And to be fair, that's done by staff skill mix, mixing up how we start and stop our clinic times. And an awful lot of that credit goes to Lindsay, who's now the senior charge nurse for both endoscopy and outpatients. So we can move staff across the piece an awful lot more flexibly than we did before. And I mean, Lindsay might want to say about what we're doing with plan for nurses, upskilling people.
So just, I think a general issue every year has been put into band 5 posts. So we've kind of looked at changing our skill mix to upskill our band 3 staff to become band 4s. We can then work more flexibly with the department. And hopefully by doing that, that will allow us more to run more clinics and more endoscopy sessions, outpatient clinics, things like that. And as far as we do try and rotate the staff through the departments now, so we can cover our shortfall staff and a lot better than we previously needed to do. Which, so we'll just help them clinics from cancelled or endoscopy rest of the cancelled due to the shortages of staff. And so hopefully going forward that will continue to increase and be more beneficial for the hospital.
That's really good, and I do think that we have to be agile and flexible, don't we, in everything that we do to get the best out of the system. I suppose, Gordon, going from 30,000 to 50,000 and hopefully to 60,000 this year, what do you think what is the capacity? Where can we get that to?
I think the capacity is back to that word car park.
I hate the word car park. Well, we'll just have to multi-story it or something.
So certainly we could potentially see more than 60,000 people in the outpatient department. It's big enough. We've got sub-wait so that patients are moved from the main waiting area to next to the clinic they're going to be seen in. So there's less time in collecting a patient, taking them to clinic, and we can do more of that. We continue to look at starting clinics at 8:45, 8:50, 9:05, as opposed to traditional 9, 9:15, 9:30. So one nurse can manage more patients. But yes, it's going to be about car park. It's going to be about buses being able to stop closer to the hospital so that we can get more patients here. And I appreciate that's not necessarily all within our gift, but all of us can work locally to start exploring how that might work. I'm conscious we do have neighbours, and those neighbours have to be consulted as well.
Yeah. I think the bus one's an interesting one, isn't it? And our two councillors have disappeared off the chat. I think we are off the call. We need to get back onto them on that one. John.
Thanks, Fiona. I think you jumped in with a bit of my question literally as I was putting my hand up. So that's great that we're thinking about the same things. And I'm currently at the community hospital on 1 day a week and hoping to get back to cycling. So that'll be one car parking space free. But I think that highlights another point, that we do need to be working on non-car transport to getting people here as much as possible for everyone who possibly can, because it's better for the environment and it's better for us to be more active. And anything we can do to enhance that wherever possible is great. And I guess I was going to ask the capacity question as well, and what are perhaps the other factors that impact on that, whether how much of it is space within the building to do different to do more stuff, how much of it is staff, how much of it is money, because it's certainly out in Dunbar, I'm acutely aware of the fact that I, as an affluent middle class GP, can easily get into Edinburgh or get to clinics, but so many of my patients really struggle to get that far, and any services that we can maximise locally in Dunbar or in Haddington makes such a difference.
Yeah. No, I think we are, you know, I think there's evidence there of us moving in the right direction. It's just how far can we move, isn't it? How far can we push that? Leslie?
I suppose it is another update from Discharge to Assess as well. We've now actually moved our staff into the Royal Infirmary, because what we were aware of is that patients were in the Royal Infirmary and staff in the Royal were not aware of the services that were available in East Lothian. And they were spending, we think, on average 6 days longer than they needed to be in hospital. So we've sent our InReach team, which is our discharge, some of our InReach Discharge to Assess, and they now are based in the Royal. What they do is they take ownership of not all our patients, but as many as we can, and we sometimes treat them, but more oftenly we assess them. We look at what other options we have and arrange support in the community for when they come home, Discharge to Assess. So it's we're aware of the pressures the acute has got, but we're also aware that we have local knowledge about these patients, and a lot of the time we actually know the patients. So we can actually go in, speak to them, we know their families, and we can get them out and comfortable and safe as soon as possible. And the data we're getting from it is very successful, not just for the patients, but also for the Royal, to increase flow, but also it's getting patients home. They seem happy about it as well. They get home sooner than they were before. So this is watch this space.
And how long, Leslie, have you been doing that? That's a fairly recent.
So it started in the beginning of November, and the project will be looked at closely by the 31st of March. The data, we have done a huge amount of research on this, and there'll be a huge amount of data, so there'll be a very large report coming out for everybody to look at as of the 31st of March. Because of its success, I think it is going to be looked at the Royal, hopefully, to be carried on, but we will give the evidence of that.
Yeah.
Which will be scrutinised by the acute and no doubt ourselves. But anything that we can do to help the patients we already know, and to help them come home and return to their day centres in some case, not necessarily care, but back to the life they had previously, is what we're aiming for.
Yeah, yep. So my plea is not a huge report, just some really good figures that show us what's
there'll be an executive summary, I promise you, Fiona, that you'll just be able to look at, and it'll be,
because that's the sort of thing.
Like a report.
That's the sort of thing we need to share in our newsletters as well. Those, you know, the success of that, and make sure that we can keep it going if that's a feasible option. One would hope so. Sorry, there's somebody else in the chat. Just bear with me. I need to flick between things. Jackie's just commenting on the travel issue about people having to get from outlying villages, but I think we've talked about the travel, and I think we all recognise it. But again, some of it is not within our gift to resolve. Okay, nobody else has their hands up, which really surprises me. I either means that we're doing the right things and you're all happy with us, which is what I'm going to assume, and you know what assuming does, but I'm going to take it on face value that we're the Shifting the Balance of Care Change Board are heading in the right direction. You would like us to keep going that way. What are there other things? The last time we did this session, there were quite a few ideas that came from people. And I'm just wondering if there are other, and I know that Gordon's taken some of them forward and he's described them to you, but are there other things that you think we ought to be looking at? Now, they need to be within our gift, but it's always helpful to have ideas. We can't necessarily come up with them all ourselves. No? Well, let's just say if people think of things that they think this should be, so bear in mind there has to be, there is an element here of if it's just for one person and one session, then it's not something that's possible probably to return to locally. But I do think that where there's a bit of a patient population, things can be done. So I think the blood transfusions example is a really good one. There's enough people to make that a viable option. So, you know, do think of things where you think, well, we do quite a lot of that local, or we send a lot of local people to have that done. Let's think of the things that they might be. John, I'm hoping you're going to bail me out here.
As much as anything, it's not something we can necessarily do, but I think just a plea for awareness, in that one of the massive things that's changed about life as a general practitioner in the last 10 to 15 years has been that the things we do and the work we do has become more complicated and the workload has increased massively. And a lot of that is a direct result of the quite appropriate shifting of the balance of care from within hospitals into the community. And although many services get extra resource to do this, general practice generally does not. And it's right that this all happens. It's really important, but I think for all of you to recognise and understand that a lot of the time these are changes that actually have an impact on how GPs work as well. It's not the GPs don't want to be doing this stuff. We do. We want to be keeping people at home as much as possible and be aware of that. And there have been some changes in the way that general practice works in the last few years that many people will be aware of, and some new services that have been put in place, some of which have made things more complicated, some of which have made things easier. But I think it's just having an awareness of the challenges and the impacts and some of the other consequences that go along with this kind of change as well.
Yeah. So I think you know, nobody would dispute that, and I think there's been a lot. I think there's an element of it takes a little bit of time for some of those changes to bed in as well. So some of the services that are now being funded out into primary care and getting them to the optimum use is also you know, we just need to allow that to bed and people to get used to not always seeing their doctor. That's not always who you're going to see. You know, you might see somebody else who's equally appropriate or equally as appropriate for, or more appropriate, may I even say, in some cases, depending on what the reason is that you're coming to the surgery. So I do think we just need to let some of those services bed in. We've had quite a lot, and I know this is an IJB discussion, but we've had quite a lot of discussion at the board about the messaging around that. And the messaging for the public, and I think that's perhaps where some of this needs to come from. That people just don't quite get yet who can do what where, and I think we do need to do a lot more of that. I think you're absolutely right. So Tom's put some suggestions in the chat for us. Resourcing hospital at home to accept more patients in a broader remit. I think that's certainly something that's been looked at. It's been looked at not by this group because we don't have the purse strings, but it is being looked at by another change board that was looking at provision of care more generally. The minor injuries issue has been picked up, and I think we've identified that would be an issue to be debated at the IJB. The outpatient IV antibiotic therapy, Gordon, you might want to comment on that. I think you already do that, but I don't know if there's a capacity issue there as well.
I think Tom might be able to see my notes. Tom, within a month that will be running from this site. We've got 2 specialist nurses coming down from the Western General Infectious Diseases Unit, and they'll be seeing 14 patients a day, and that'll be a 7-day-a-week service.
Yeah, that's good. That's really good. That's getting a thumbs up and nods from our GP colleagues.
Thanks, Gordon. That's really helpful to have that that update. It's just one of those things that, yeah, it's great to be able to deliver that locally for our patients. Thanks.
Absolutely, and from home rather than having to be admitted for IV antibiotics. Lorraine, did you want to come in on that?
I just wanted which is a really good development, but I just wanted to just go back to Tom's point about hospital at home. So we've just received some government money or some HIS money, and we are expanding our staffing base in hospital at home. We're recruiting 2 new nurses, and we've just recruited to a clinical fellow post, which will allow us to, as of the beginning of the summer, when everybody's in post, will allow us to expand hospital. We'll pick up more patients from the GPs, and we are in discussions about what is it we do, what do we take, and there is Tom, there's a group right across Lothian looking at hospital at home, and what their remit is and what their purpose is, so that they can respond to making sure they keep people at home. So, and that's looking at making sure the hospital at home services is run universally. That we will be in a position to absorb more patients probably about the beginning of the summer, when recruitment comes to its fullest. It's complete point.
That's really good as well. That's another positive development, I'm sure. So I think it's really good to hear just how much is actually happening. Jackie, did you want to come back in?
No, it was a flashing happy hand.
Oh, it was a flashing happy hand. Jolly good. Excellent.
Because I wasn't sure how to do emojis.
You don't. No, sometimes it goes a wee bit funny, doesn't it? Excellent. I think this may be a very happy note to end on there, actually. I'm just going to check the programme and see if it says I'm supposed to do anything else. Open forum, we've done that. Opportunity to discuss, we've done that. Pose any further questions, we've done that. Okay, does anybody else want to have the last word? No. Okay, so it just remains then for me to say thank you to everybody who has participated. It's been really good to explore what's been done and what is in the process of being done, and to start to look at what we can do in the next 6 months. I suppose as one of the co-chairs with Lorraine of the Shifting the Balance of Care Change Board, I am absolutely going to say we will do our quarterly newsletter, and we will be back here in October. There you go, I've said it, we will now have to do it. I'm hoping that we'll have lots more to report at that stage. John, I noticed in the chat, said he's just taken over one of the other Shifting the Balance of Care Change, one of the other change boards, not Shifting the Balance of Care, one of the other change boards, and he's going to go into competition with us in terms of his stakeholder engagement. So we'll try and do our best to keep ahead there. So we'll welcome you all back in October. I just saw Jennifer put her head in her hand. She's thinking, I've got 2 of these to do now. 4, 5. But yeah, we'll see you all back in October. We'll hopefully have lots more to report then, and wish you all a good evening. Thank you very much.
Thank you, everybody.
Thanks, everyone. Bye.
Bye.